Thank you for that wonderful introduction. And thank you to my wonderful senior colleagues who've just set an amazing benchmark. And now we're going to talk about cardio-kidney metabolic disease. We're going to focus primarily on finerenone and some of the things that we know, some of the trials. So let me begin. We know CKD, very common, 20% of our population. If you're over 40, 45% of our population suffer from CKD. So we are drowning in CKD, we're drowning in hypertension, we're drowning in diabetes. 1 in 3 adults have diabetes, 1 in 2 adults have hypertension. We are expected to double the number of people on renal replacement therapy every 20 years. So more and more people on dialysis, more and more people requiring a transplant. That is going to have a significant burden on our healthcare system, which is already straining. So CKD, we know, diabetes and hypertension primarily. This is an important slide because it goes into the pathology, the pathophysiology. Hyperglycemia causes inflammation. Inflammation leads to fibrosis. Initially, you get microalbuminuria, then macroalbuminuria. Your kidneys adapt initially. You have a normal GFR or a high GFR, and then eventually your GFR goes down, and you go into a low GFR state, eventually to ESRD. But the important thing are those 2 bars at the bottom. Before you get kidney complications, before you notice something's wrong with your kidney, you start getting cardiovascular complications. You have macrovascular complications related to peripheral arterial disease, CVA, heart failure, MI, non-fatal MI. So that's what we're dealing with. The pathology, the pathophysiology begins well before you actually present to the OPD, when you actually present to the emergency department. If you notice your HbA1c is 6, that's when you start secreting protein. It starts at a very low level and eventually it goes up and up and up. So we need to do something about it. We need to treat the patient as a whole. As Professor Shahbaz said, we can't think of ourselves as cardiac physicians. We have to think of ourselves as cardio-kidney metabolic physicians. And then we'll get to the root of it. Obviously, prevention has a major role. The previous speakers have mentioned about rehab, prevention, lifestyle, everything, devices, it all plays a role. But we need to think of ourselves holistically. We can't define ourselves by intervention or electrophysiology or heart failure specialists. We have to think of the whole. So we all know if you've got diabetes, it's bad, but it's doubly bad if you have CKD. Everything, your risk of heart failure, MI, CVA, peripheral disease, and death more than doubles if you have CKD on top of diabetes. So we need to stop the CKD before it happens. And we've got an armamentarium. We can control BP, we can normalize HbA1c, weight loss, smoking cessation. We've got these wonderful drugs. Some of them were talked about earlier on. RAS inhibitors, SGLT2 inhibitors. I'd like to introduce MRAs as well, which we're going to talk about in detail, and the wonder drugs, the GLP-1 receptor agonists, which are going to revolutionize healthcare around the world, especially in our country. But what are we going to focus on today? Finerenone. It's a non-steroidal MRA. It works on the RAS system through its inhibition of the effects of aldosterone. So we know the mineralocorticoid receptors. We know they're antagonized by spironolactone and eplerenone. But we also now know that inflammation is the key. It causes, when you overstimulate the mineralocorticoid receptor, it drives inflammation. It turns on those pro-inflammatory genes and activates cytokines, TNF-alpha, interleukin-1, interleukin-6, the usual suspects. So let's talk about finerenone. Now, what's new about finerenone? Finerenone is a bulky molecule. It's big. It's bigger than spironolactone. It's bigger than eplerenone. It has very good selective potent. It really grabs onto that mineralocorticoid receptor, and it downregulates those pro-inflammatory genes. And it exerts an anti-fibrotic and an anti-inflammatory effect. It works all over the body on all of these organ systems. We're not going to get into that. This was discussed earlier on, some of the trials, including Fidelio and Figaro, which we're going to talk about, and we're going to focus on the fine arts trial. So once again, comparing the mineralocorticoid receptor antagonists, What's different about finerenone? Finerenone is fast acting, it's got a very short half-life, it doesn't have all of those nasty sexual side effects. The gynecomastia, the impotence, the decline in sexual function is not there with finerenone. It works in a different way. So what do the guidelines say? KDIGO, first line, if you've got CKD or you're at risk of CKD, SGLT2/1, obviously, metformin. Those are sort of first line, but second line, additional therapy, we've got non-steroidal MRA, assuming you've got albumin-creatinine ratio, microalbuminuria of more than 30 milligrams per gram. So these are the weapons we have. These are the, you could say, the pillars. We've talked about pillars. These are the 4 pillars related to type 2 diabetes and CKD. So if you've got type 2 diabetes, we want you not to get CKD. And if you're getting CKD, we want your CKD not to progress to end-stage renal disease. So these are guidelines, ADA, KDIGO, American Association of Endocrinologists, ESC. All of them are kind of universal. If your eGFR is more than 25, and you're on maximum RAS inhibition and you've got a degree of microalbuminuria, you need to put your patient on a mineralocorticoid receptor antagonist, in this case finerenone. So when is it indicated in CKD? CKD with type 2 diabetes, according to the guidelines, we stop sustained decline of eGFR, we prevent ESRD, we prevent cardiovascular death, we prevent non-fatal MI, and now the crux of this presentation, hospitalization for heart failure. So starting dose is 20 if you have a good GFR. If you don't, it's 10 in this scenario, and you need to watch your potassium because hyperkalemia happens. Okay, not indicated in pregnancy. So what are the landmark trials? Fidelio, Figaro, and FINE-ARTS is what we're focusing on. This is Fidelio in type 2 diabetes and CKD. It was one of the earlier trials. Let's get to the crux of it. The primary endpoint was the Fidelio DKD met its primary and key secondary endpoints, relative reduction in kidney failure and also in these cardiovascular effects. If you look at the slide, the part of the slide on the right-hand side, a significant reduction in heart failure, hospitalization, cardiovascular death, non-fatal MI, non-fatal stroke. So that was the crux of the Fidelio DKD. It also reduced albuminuria. So let's get on to the next trial, Figaro. Figaro, similar, looking at cardiovascular outcomes, looking at renal outcomes. So let's get to the slides that matter. Figaro, this was the primary outcome, time to CV death, time to non-fatal MI, non-fatal stroke or hospitalized heart failure. A 13% reduction, which was statistically significant. This was the forest plot. It was primarily powered by hospitalized heart failure, so you can see that there. So let's get to the finishing line, which is the FINE-ARTS trial. FINE-ARTS was a double-blind, placebo-controlled trial testing the hypothesis that finerenone would reduce CV death and worsening heart failure. And it was the superstar trial of ESC 2024. We used a higher dose, 40 milligrams if your eGFR was above 60, 20 milligrams if your eGFR was less. Potassium was checked, and 6,000 people, 3,000 on each side. There were age-matched control, and this is the critical slide of this presentation. 16% reduction in cardiovascular death, total worsening heart failure over a median follow-up of 32 months. And heart failure events was what powered it. So this is the new superstar. This is the drug. There was an improvement in KCCQ, very low compared to placebo. If you look at the placebo, serious adverse effects, 40%, placebo 38%. There was an increase in hyperkalemia, but I would like to add there was a decrease in hypokalemia. And as an electrophysiologist, I'm more afraid of hypokalemia than I am of hyperkalemia, because hypokalemia has a greater tendency to cause VT. So this is the new superstar. This is going to be the next pillar in the guidelines, I'm quite sure, with the treatment of heart failure with mildly reduced ejection fraction and heart failure with preserved ejection fraction, which was what the FINE-ARTS trial was all about. So the conclusion of this trial, if you've got HFpEF or HFMRF, finerenone reduces your risk of the composite outcome of cardiovascular death and total heart failure. Hyperkalemia was more common, 8% compared to 4% in placebo, but hypokalemia was less common. And that's really important. So the data is there. It's not in the guidelines yet. And this is the final slide. So the non-steroidal MRA, finerenone, is a new addition to our armamentarium in the management of CKD and heart disease. There's wonderful data out there. We've got very, very strong data, and I'm sure it's going to be incorporated in the heart failure guidelines soon. You need to stick to your basics: RAS inhibition, tight diabetes control, tight hypertension control. You need to monitor for hyperkalemia. It's not to be used in pregnant patients or people with an eGFR of 25 or less than 25. So that's it. The bottom line is this is out there, it's going to be there, and we're going to use it. Thank you very much for listening.